This EHIV review program is presented by DKB Med Radio.
So we've seen, and it's been documented in Philadelphia here, that viral suppression rates go down after delivery. And so there's something we're always worried about, like, is this person, stopping their antiretrovirals, then they're going to get viral rebound, and we don't want to risk the transmission. So there's a lot of factors in there and a lot of different groups involved. So we do keep a lot of different variables going on there.
ART and pregnancy, revised considerations. Welcome to EHIV Review. She wanted to be a mother. The myth told her, no way, HIV-positive women's bodies can't handle pregnancy. But the reality said, women living with HIV can take care of their pregnant bodies the same way and achieve the same healthy results as HIV-negative women. They wanted a family, but the myth told them, no way, HIV-positive men can't be biological fathers. But the reality said, PrEP can allow a woman to conceive naturally with an HIV-positive man. They wanted a healthy baby. The myth told them, no way, babies born to HIV-positive mothers are unhealthy. But the reality said, the latest research shows that the chance a mom living with HIV will transmit the virus to her baby is less than 1%. She wanted to deliver her baby naturally. The myth told her, no way, HIV-positive moms have to deliver via cesarean section. But the reality said, unless a woman's HIV viral load is very high, the recommendation is for a vaginal birth. When myth confronts reality, reality always wins. To provide further insight into the realities, we're joined today by Dr. William R. Short, an associate professor of clinical medicine in the Division of Infectious Diseases, as well as an associate professor of clinical medicine in Obstetrics and Gynecology at the Perelman School of Medicine at the University of Pennsylvania. For our guests' disclosures and additional CME information, please go to our website, ehivreview.org, and select the Volume 10, Issue 10 link. I'm Bob Busker, executive producer of DKB Med's e-literature review video programs. Dr. Short, thank you for joining us today.
Great. Glad to be here. Thank you so much for having me. I'm excited.
Our overall learning objective for today's discussion is to assess strategies to reduce perinatal and postnatal HIV transmission. The focus of this first part of our conversation is on describing the decision-making process for determining the need to switch ART for pregnant patients presenting to care. So that said, if you would please, Dr. Short, start us out in the clinic with a patient scenario.
Sure, I'd be happy to. So we have a 25-year-old female who is pregnant, who presents to the prenatal clinic to establish care. She is currently 16 weeks pregnant, and that's established and confirmed by an ultrasound. She's receiving long-acting cabotegravir and rilpivirine every 2 months, and she's virologically suppressed and doing very well in this regimen.
So 25 years old, virally suppressed on long-acting cabotegravir plus rilpivirine, and newly pregnant. Before we discuss the considerations for potentially changing her regimen, let me ask you about how she got to her current ART situation. Like most patients, she likely started on oral therapy. What was the reason for the switch from oral to long-acting injectable therapy? Was it a tolerability problem?
That's a great question. So, no, it was not really a tolerability issue. Like you said, most patients, she started on oral therapy, did well. And then over time, because we know starting on therapy is a lifelong process, right? Once you start, you're on for life. And she started getting pill fatigue. She was really tired of taking them. And then she started missing doses. But again, the regimen was very simple, well tolerated. It was just that she had to do it all the time. And if she was out for an evening, she would totally forget about it. So when this long-acting formulation was approved, it was discussed, and she was very happy to start it. And she's been really happy now receiving every 2-month injections.
But rilpivirine, there is a notable lack of data about using that regimen in pregnancy. Was that discussed with the patient before her initial switch to long-acting therapy?
That's really an excellent question. So when I met the patient, I actually asked her that, and she had not had the discussion. And often what happens is when a drug gets FDA approved, there's often a lack of data regarding pregnancy. And particularly, we're looking at a few things. We're looking at pharmacokinetic changes, and we're looking at safety during pregnancy. And so what often happens in clinical practice is someone's seeing a patient, they're talking to the patient, they tell them their story just like this patient. I am tired of taking pills. I want to start on injectables. And they forget that a pregnancy can occur. So at the time of that decision, which again is an important concept, just because maybe at diagnosis the person wasn't interested in getting pregnant, that doesn't mean that doesn't change as it was for this patient. So it was not discussed when she initially presented to care. And now, as we'll see, this becomes a problem because these drugs have very long tails. And for her, this will remain in her body for over a year. And so it'll be with her throughout the duration of the pregnancy.
Thank you, doctor. Now, let me ask you, what are your considerations for changing antiretroviral therapy in this pregnant patient?
That's another great question. So typically when someone presents on a regimen, and even if there's a lack of data, what we typically say is there anything that stands out that we see there's a safety issue, or is it teratogenic? And if there's not, the recommendation put forth by the guidelines panels is that you recommend you have a discussion with the patient and consider staying on that regimen. Because obviously changing and swapping out can cause problems, viral rebound, virologic failure, and maybe introduce new side effects that she didn't have before. So here's someone who's tolerating an injectable. Now you're going to pull it away and then introduce pills. And we've already told you that, missing, she was starting to missing pills. So all these things are really critical. So that's what happened here. We had a long discussion about it, and that's really what you need to do.
And the results of that discussion?
Let's just say she says, I really want to change therapy. So what I would do is I would go with one of the regimens that's preferred by the pregnancy guidelines. And typically they're integrase-based regimens. So they're dolutegravir or bictegravir-based regimens. And that would be in combination with 2 nucleoside reverse transcriptase inhibitors. And they're pretty standard.
And injectable agents inappropriate in pregnancy?
Drugs that are typically we recommend not using are drugs that have the booster, and that's cobicistat. And the reason is when you look at the pharmacokinetic changes that occur throughout the pregnancy, right? So the induction of enzymes, the change in the volume and distribution, all that brings about a decline in the levels of the drug. And specifically when they looked at cobicistat, those levels were markedly decreased. And there was a concern that the panel decided that's one where you really need to have a conversation and not consider using them.
Thank you, Dr. Short. Let me go back to my question about oral options. Dolutegravir, bictegravir, ritonavir boosted darunavir. Would any of those oral agents be appropriate for a patient who's been unable to adhere to pills, especially when she's happy and has been adherent to every 2-month cabotegravir, rilpivirine injections? So even though the data about its use in pregnancy isn't in yet, let's look at rilpivirine again. What should the HIV physician know before deciding to prescribe it?
Sure. So before prescribing it, obviously, I think a big piece would be education, right? So you want to educate someone who's of childbearing potential that if they become pregnant, that this drug, even if you stop it, will still continue to hang around and be present for almost a year. And so I think that point really needs to be laid out. The other thing is we are lacking key data. And the 2 things we look at, because we already have efficacy data that came from the registrational trials when the drug got approved, but we're lacking in remember, rilpivirine is 2 different drugs. So for cabotegravir, we actually have pharmacokinetic data that shows it looks pretty good. For rilpivirine, that seems to be the problem. So remember, rilpivirine not only is injectable, we also have an oral formulation. So we do have safety data from the formulation. Where the problem exists is that oral rilpivirine, we know the drug levels are also low. Now, the recommendation when they reviewed the drug levels was there's really no need to make a dose change. You're fine with the dosage that you have in standard rilpivirine oral dosing, but maybe check your viral load more frequently. What we don't have is pharmacokinetic changes and how that affects the levels when you're given a long-acting formulation. And so there have been two modeling studies done that show that if you're giving every 2 months, it most likely will lead to much lower levels that could potentially lead to virologic rebound. And if you're using every 1 month, that may be the same as well. So in the guidelines, what's recommended, if someone conceives on that and the patients decide they want to stay on that regimen, they should probably switch to every 1 month for the duration of the pregnancy.
Interesting recommendation. What about adverse events or other safety concerns that might arise from the caberpivirine? What, again, does the clinician need to know before prescribing?
Sure. Again, data is very limited. What we have is what we see in the registrational trials. We don't really know about pregnancy. Now, what's starting to come out is we have data from the prevention trials where cabotegravir was used. So they're the HIV prevention trial network studies. We have data from there that's reassuring. And, there is a cohort study that's being done, actually something that I led, where we're accumulating evidence. It's all retrospective. And right now things look good, but the numbers are small. And so we're really left with a paucity of data around this adverse events. And again, they're the two things that you want to know to feel comfortable prescribing drugs in pregnancy is what do the pharmacokinetic changes that you see for normal pregnancy do to the drug levels? And number two, are there any safety concerns for both the mother as well as the newborn or the fetus?
Well, thank you, Doctor. Our key learning focus for this part of our discussion is to describe the decision-making process for determining the need to switch ART for pregnant patients presenting to care. Based on our conversation, what are the most important things that our learners need to keep in mind?
So I would say first and foremost, maintain virologic suppression. So the second point is you don't want to switch antiretrovirals in pregnancy reflexively, right? It's important to avoid unnecessary regimen changes that may diminish virologic suppression. I think the third point is when you are talking to someone of childbearing potential, you really want to make sure that the drug has sufficient data to be used. And so you can sort of balance those risks and benefits out like we talked about. And finally, always engage in shared decision making. It's really important to involve patients. I find in the 27 years that I've been in practice, I've done so much better when I talk to someone and we're on the same page. They feel like they've had a hand in making a decision about their care, especially when it comes to antiretroviral therapy. I never want to tell someone, here's what you need to do. That dynamic does not work. So I think they're the 4 points that I would really say if you walk away from this session, that's what you should walk away with.
Nice summation, Doctor. Thank you. And we'll return with Dr. William Short from the University of Pennsylvania in just a moment. Providing the best care for your patients takes more than identifying the most relevant information. It takes expert opinion and analysis of the data, combined with expert advice about how to most effectively put that information into practice. It takes the Johns Hopkins University School of Medicine e-literature reviews. Top experts in their specialties, selecting the most important peer-reviewed literature, analyzing the information, and explaining what it can mean to clinical practice. E-literature reviews, independent medical education, CME, certified by Johns Hopkins University School of Medicine, and presented without charge by DKB Med. Welcome back to today's EHIV review program. Our guest is Dr. William Short, Associate Professor of Medicine and Infectious Diseases and also OBGYN at the University of Pennsylvania's Perelman School of Medicine. Our overall learning objective for today's discussion is to assess strategies to reduce perinatal and postnatal HIV transmission. The first part of today's discussion focused on the decision-making process for determining the need to switch ART regimens for patients who become pregnant. Let's turn now to the second focus of today's conversation, to discuss how to increase patient awareness of the pros and cons of breastfeeding while on ART. This is an area where there's a lot of confusion and a lot of concern. So if you would please, Dr. Short, take us back to the clinic to start sorting this out.
Sure, absolutely. So we have a 30-year-old pregnant female with HIV who's presenting to the clinic for a routine follow-up visit. She's been doing well. She's on co-formulated bictegravir, emtricitabine, and tenofovir alafenamide. She's virally suppressed. This is her first pregnancy.
Assuming she doesn't ask you first, how would you introduce the topic of breastfeeding?
Right. It's really important that this is done. So it's excellent question. So when you're seeing someone who's pregnant, it's really important to bring this up. And the question is, how do you bring it up? So first, to give you context, in 2023, the pregnancy guidelines shifted. It was the first time where it was no longer you should not breastfeed. It was really about choice, having a discussion with the patient. So because of those changes, it's really important that you approach this and they're made aware, just like we talked about in other cases, shared decision making. So I typically approach and I use very open-ended questions, and a very simple thing I ask, I never say, you can't breastfeed. Can you do this? I say, what are your thoughts on infant feeding? And that really sets the stage for where the discussion's going to go. And oftentimes I'm met with, well, I can't breastfeed. And then my response is, that's not what I said. What are your thoughts? What would you want to do? And then this conversation starts. And that's really a great way to introduce the concept of infant feeding and whether someone is interested or not in pursuing breastfeeding.
A simple and direct lead-in to open the topic. Nice strategy. But what happens next? Go a little deeper for us, if you would, please, Doctor. What specific counseling points would you want to communicate during this part of your conversation?
Good. So let's talk about the timing. I think when you're discussing with a patient this topic, there's going to be so many questions. For some, it's not a simple yes, no. My answer is always, what's going on at the time. If someone's newly diagnosed, that may not be the time to discuss it. But if I have someone who's coming in, their routine, they've had HIV for a little while, they're very comfortable, they're here for their pregnancy, I bring it up very early on. Why? Because there's a lot of counseling points that I'm going to sort of go through in the next couple of minutes that I want to make sure they get through. And they often don't catch everything in the first time. So I do bring it up. I ask what they know, what they've heard, because that's important. One of the first things I ask about if they say they want to breastfeed are, what are the motivations? Why do they want to breastfeed? Is it something they really want to do? Is it something because there's family pressure? Is it something they feel they have to do? Is it cultural? What are their motivators for why they want to breastfeed? And then one of the big things I hit pretty early on is discussing the risk of transmission. And this is a big one. So, the typical transmission risk that we quote is from a study called the PROMISE study, where they randomized either mother or infant to antiretroviral therapy. And what we saw there were very low rates of viral suppression. So we often tell individuals, that your risk of transmission with a suppressed viral load is less than 1%. So for a lot of patients hearing that, that's an immediate turnoff. And they say, well, it's not zero. And that's the point you have to make, is that it's not a zero risk, right? It's not a zero risk. I can't tell you zero. It's less than 1%. And believe it or not, that for a lot of people, they do not know that, because often they hear, well, in Africa, people breastfeed, or people over here breastfeed. Why can't I? And they don't know that there still is a low risk of transmission. So we start with that. And then once someone says, okay, I'm willing to accept that less than 1%, then I move on to all the other counseling pieces of, what's going to happen, where you would be referred to, make sure you stay on your medications, remain virally suppressed. What's going to happen to your newborn, right? The newborn's going to need testing. The newborn's going to need treatment. Maybe not. The guidelines are a little unclear on that. They don't really issue pure guidance on that, but there's a lot of points we need to cover. And so what we've done at our institution is we have developed a teaching tool where I start the conversation. I'm seeing someone who's pregnant. OBs and I work together. And then I refer them off to our pediatric group, and they do another consultation. So by the time they've met and they either do a virtual visit or they're going to do an in-person visit. They bring family members if they want. And then they also meet a lactation specialist. So it's very complicated. And we have grown our program over the last 2 years to where it is now, where we feel that we give a comprehensive educational package to someone if they desire to breastfeed.
A comprehensive educational package. That's certainly what you're describing. Two quick clarification questions, please. In your practice, what percentage of patients have you found decide against breastfeeding, and have you seen that number rising or falling in the recent past?
Right. So I would say that the number of people who decide against breastfeeding is still pretty high. I mean, we've looked at our numbers. We have maybe about a quarter of our patients. So we see about 100 a year who come through our institution that I specifically provide care for. So maybe a quarter of them decide they are interested in breastfeeding. And so it has gone up, right? Because it used to be, we would ask it, maybe it was one or two. Now we're seeing about a quarter of people who are interested. And the reason is, I think, because we have this comprehensive program that really supports them through this. Whereas before it was really simple. It's not recommended you breastfeed, and we put an end there. And then what we've actually seen and heard, and we've talked about this with patients is, have you ever breastfed on your own? And we hear often, yes, I have. Even though I was told not to do it, I did it. And so that's one of the things we really want to make sure happens is that we make sure we give the counseling and the support to prevent that from going on behind the scenes. And like I said from the previous section, what we see is when people say no, it's often when they hear that it's not a zero risk, that there still is a very low risk of transmission. That for some people says, no, I cannot take that chance. I just saw a patient last week who was struggling. She wanted to do it, and she said, what would you do? I said, I'm not in that situation. That's something I will not answer for you. But we talked through it, and she was very clearly, I helped her realize what she wanted, and she wanted me to say zero risk of transmission, and I couldn't. And because of that, she said, I'm fine with actually doing formula feeding. But the beauty of that was she made the decision, right? It's not like I walked in and said to her, you cannot breastfeed, which is what was done before, and it makes people feel terrible. So this was, I let her make the decision. I gave her the tools, I gave her the education. She actually met with the pediatricians, and despite all that said, I cannot put my child through a less than 1% risk. I would never be able to live it myself. And she answered it for herself.
Shared decision-making. Give the patients the facts and support the decision they make based on those facts. Nice strategy. Talk to us now, if you would please, about follow-up care for both the mother and the infant if breastfeeding is chosen.
Great. So if someone decides to breastfeed, as I mentioned, we get them to the point where they're at delivery. In the third trimester of pregnancy, we have them meet with a lactation consultant to go over all the different logistics of what's going to happen when you get to the hospital. What should you expect? And that's really been helpful. That is something we added about a year into our program. We were not doing it before, and we got people to the point where they got in the hospital and the baby was having problems latching. And so we then let's introduce our lactation consultant here. That's really been helpful. So that's the first piece. Once they deliver, they will follow up like they normally would. So if you have someone who's HIV exposed, an infant, they will get follow-up, right? They're getting follow-up for testing. They're often given medication for a certain period of time. So here, if they decide to breastfeed, they're going to be followed a little longer. They're going to be followed for the duration of the breastfeeding. And, this is where it gets, it varies institution to institution, because the guidelines really aren't clear on the testing. It's clear for the mother, stay on antiretrovirals to maintain viral suppression. Where it's unclear is, do you need to give the infant 1 drug, 2 drug, 3 drug? There's no guidelines there. I could tell you what we do. What about testing? How often should you test the newborn? It's not really in there either. So we've come up with our own algorithm that's worked, and we follow that. But if you talk to somebody else, they're going to say we don't give the newborn any antiretroviral drugs. So that's an area of the guidelines that's still in a lot of flux right now, and really is unsure. So one thing we've seen, and it really becomes critical, is that in the postpartum period, there are a lot of things going on, right? And besides the breastfeeding, you have someone who's a new mother, maybe they're struggling, they have other children, other responsibilities, and antiretrovirals become less of a priority for them. And so we've seen, and it's been documented in Philadelphia here, that viral suppression rates go down after delivery. And so there's something we're always worried about, like, is this person, stopping their antiretrovirals, then they're going to get viral rebound, and we don't want to risk that transmission. So there's a lot of factors in there and a lot of different groups involved. So we do keep a lot of different variables going on there. So really, there's a whole group of individuals involved in the care once the decision is to breastfeed. And again, I will say, this is not every institution. Some institutions are just ramping up their programs. They're feeling comfortable with it. And then there's some that are doing nothing with it at all. So it's very, 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 there's not one size fits all. Every program is different. Talk to another provider from another institution. They may do something completely different.
So your program at UPenn Perelman seems very well designed and very complete, and as you've noted, very patient-centered and patient-supportive. Have you found the programs at other institutions to be similar?
Yeah, no, it's not at all. And I would say across the U.S. it varies. And as I mentioned, some are very, very involved like we are. They have elaborate programs. Others are just starting. They're trying to feel their way. And then there's others who are really against this approach, largely because of that less than 1% risk of transmission. And so some of those practices are not supportive and will flat out tell patients, you cannot breastfeed, despite what guidelines are saying. And some have even gone as far as call child protective services or, getting human services involved, which is really wrong and is actually a bolded bullet point in the pregnancy guidelines to not involve child protective services. And as you can imagine, if you're someone who's trying to make a decision about what to do, having that threat really is really not great. And it makes the pregnancy not so great for you as well.
Well, thank you, Doctor. Our key learning focus for this part of our program is to discuss how to increase patient awareness of the pros and cons of breastfeeding while on ART. What are the key things you'd want our learners to take back to their practices?
Right. So first and foremost, make sure you use open-ended questions when you're approaching a patient, asking about their choice for infant feeding. It really stimulates a much better conversation. Second, you want to discuss what are the other options if they decide not to breastfeed. So do they want to formula feed? Do they want to talk about donor milk? So there's a lot of other options. It shouldn't just be one size fits all. It's what are the other options that are available? Number 3 is just letting them know that, if you decide breastfeeding, this may involve additional monitoring, and monitoring in terms of viral load for both you and the newborn, and then treatment as well. Treatment, you must stay on treatment, and then also, depending on where you're going, treatment for the infant as well if you choose to breastfeed. So that's the third point. And again, finally, I think we talked about it briefly with practices that are not so supportive, is really involving someone like child protective services. It really should not be involved, or even threaten. You shouldn't threaten someone with that if they make the decision to breastfeed.
From the University of Pennsylvania's Perelman School of Medicine, Dr. William Short, thank you for sharing your knowledge and expertise with us in today's EHIV review program.
It's been my pleasure. I appreciate the opportunity, and I really thank you for having me on.
For DKB Med's EHIV review, I'm Bob Lusker.